All right, everyone, I think we're ready to get started. Thank you very much for coming today. We look forward to hearing your questions here in a little bit, but before we get started, I want to welcome everyone in the room. We have a great showing today, and also everyone online who is joining us. We are recording this so that we can post it later for anyone who has any questions or wants to learn more about the PASSE. Let me go to my next. Can we share the screen, please? Share the PowerPoint. All right, we will begin at 12. We started off well, right? But that is okay. So I want to introduce our speakers today. I am Lainey Morrow. I work with DHS Communications, and I help to develop resources like the ones you picked up on the way in today. And we have Paula Stone, who's the Deputy Director with the DHS Division of Medical Services, Melissa Stone, who's the Director of the DHS Division of Developmental Disability Services. And then we also have with us today Dina Perry, who is the PASSE Ombudsman, and Tanya Giles, who is the PASSE Provider Liaison. And I wanted to invite them up here to introduce themselves to you and tell you more about what they do. So why don't y'all come up?
Good morning, everybody. How's everybody doing? I don't know if I need this mic or not, but okay. Okay. Well, again, my name is Dina Perry. I'm with the Division of Medical Services. I'm in the PASSE Ombudsman Office. My primary role is to ensure that our families and beneficiaries are getting what they're needing. If they have any issues or complaints about kind of what's going on with their passes or just the services that they're getting, I'm there to assist them and hopefully navigate them through that process. So if y'all have any questions or concerns that may come up, feel free to call me. My direct number is 501-320-6006. We're working on a couple of other enhancements. Yes, ma'am. Yes, ma'am. My number is 501-320-6006. And like I said, if you have any questions or concerns, please feel free to call me. Thank you.
Good morning. My name is Tanya Giles. I'm the Provider Liaison. I hope I'm not busting your eardrums. I serve as a bridge of communication between the providers and the PASSES. I can answer questions about the PASSE model of care. I can assist with provider enrollment and other general questions. If you're unsure of how to contact the PASSES or have been unable to contact the PASSES, let me be your one-stop shop. Just call me and I can help you with that. Let me talk to you about some common questions that I've gotten from some providers. One question is, would I be considered as a PASSE provider? The PASSE model was created to provide care for Medicaid recipients with high levels of needs. This means caring for the whole person, which will require services from all Medicaid provider types. You, as the providers, are essential to the success of this program, and we value your contribution. Another common question that I get is, why should I become a PASSE provider when I have very few or not any PASSE recipients? Well, the Medicaid recipients' health needs are constantly changing. And by becoming an in-network PASSE provider, that will ensure that you can continue to provide care for your Medicaid clients regardless of what PASSE they're assigned to. And one more question that I get commonly, why should you join all 4 PASSES? It's free advertising. You will be listed as an in-network provider with all 4 PASSE rosters. Again, you can continue to provide services for all of your Medicaid recipients, regardless of what PASSE they're assigned to. And as an in-network provider, again, it will be a lot easier for you to submit your claims. My contact number is 501-320-6189. It's up there on the screen. And one more thing, y'all, I didn't mean to take too much time, but let me just say this. I want to share a story with you, a quick story. I had a PASSE provider call me. We've developed a relationship. There was a homeless gentleman that he ran into several times. He got the gentleman's name, some of his personal information, and he called me. And from there, we contacted his PASSE. His care coordinator had been actively searching for him. So she she was able to get in contact with them. He was having a behavioral health crisis at the time this provider saw him. Not his provider, just a provider that had been associated with him. Well, he was having like I said, a behavioral health crisis. The care coordinator was able to procure permanent housing for him, the treatment that he needed, and in all, improve his quality of life. And this is from a provider that understood what the PASSE's goals are. And so I'm just really glad to be a part of that. And like I said, feel free to call me anytime, and I'll do everything I can to make this process as seamless as possible. Thank you.
Thank you very much,
Yes,
Dina
ma'am.
and Tanya. Their information is on the screen. So hopefully you had some time to write their phone and email down. So I just want to give you an idea of what we're going to do today. The first part of our presentation will be some information about what the PASSE is and what they do, but mostly for beneficiaries and families. And we will take a good amount of time for beneficiaries, families, caregivers to ask questions that you have. And at that time, we'll get to hear more from Paula and Melissa, and I will walk around the room and make sure we get your questions on the recording for everyone. Then at our second half, we're going to be able to answer questions for providers and give them a little bit of information. So I just wanted to give you an idea. If you're like me, you want to know what are we doing today. These are just some of the topics we're going to cover today. We're going to talk about what is a PASSE, who do they serve, what's the purpose of the PASSEs, why did we need to make this change, what should new members expect and experience, what's the timeline like, what will be happening, and so what are responsibilities of the PASSEs. We'll talk about care coordination. We will talk about global payments. We'll try to talk about everything that you are interested in today. And if we don't, you will have the opportunity to ask when we get to that, the Q&A part. But we will last go over resources that will help you when you leave here today, make sure you can get information. And then for providers, we will make sure to cover the things that you're interested in second, which include what you can expect, how you would be reimbursed, when you'll be able to check for which clients are in which PASSEs. So before we get started, I know there are people in here who don't speak our language all the time, and I want to make sure that you know if we use a shortening of a word. So if we say BHS or DDS, BHS is Behavioral Health Services and DDS is Developmental Disability Services. If we say beneficiary, that means a person who receives Medicaid. If we say provider, that means anyone who's licensed in Arkansas as a Medicaid provider who serves clients' basic medical or specialty service needs. So that includes doctors, nurses, hospitals, clinics, therapists and counselors, and pharmacists. And then the DD waiver, there may be people in here who are on the DD waiver, but not everyone knows what that is. DDS utilizes this waiver to provide many services such as supported living, to eligible children and adults in their homes and communities. And the DDS waiver is not the same thing as TEFRA. So we wanted to let y'all know TEFRA stands for Tax Equity and Fiscal Responsibility Act. And it is a program that can help families with children younger than 19 who have a disability receive care in their homes rather than in an institution, and people who are on the waiting list may be using TEFRA, as well as other people who aren't on the waiting list. So I am going to turn it over to Paula, and Paula is going to talk to us about why the system needed a change and why we chose the PASSE.
I think we had not been using these slides when we've talked about the PASSE, but to me it's important to ground us in why the system changed. So I think the system was going really, really well for some people. Some people not so much at all of these populations. And so first of all, we'll talk a little bit about financially for our state, why the system needed a change. But the decision wasn't only financial. There were other reasons for that change. I'm going to start with the financial piece of it. And maybe I should have started with the other piece of it, because I really do believe the financial piece is not as critically important as the other piece, which is making sure people get their services that they need and the right services. But what happened is we started with this analysis of 2015 data. And we showed that 74%,
Thanks for that feedback, friends online, for telling us what you're experiencing. Paula is going to move her microphone up for you. Yeah, let us know.
Let us know, everyone online. It's not better.
Here, Paula, we'll just let you use this hand mic.
Okay. All right. So can everyone online hear me now? Good. So we're talking about the need for change to the system. And to also ground this in just Medicaid data, for our Medicaid system, we serve over 900,000 people are Medicaid beneficiaries. And so just given some context there, our total Medicaid program is I think about $8 billion for our state. And so that's the broader Medicaid program. So we analyzed the data in 2015 to look at our Medicaid program as a whole. And what we found was that for the special needs populations, those that are aging, blind, disabled, most of those claims were for institutional care. And services to high-risk population, including those who have additional medical cost. So many of our special needs populations, not only do they need services for their specific issues, for instance, counseling for somebody with behavioral health, they also have associated high needs for medical services in addition to those core services. Our key health value improvement programs, so we have been doing some key health value improvement programs across Medicaid, across populations for several years. And that was person-centered medical homes. And then we did episodes of care, and we did several episodes of care, some for behavioral health populations. So we did attention deficit hyperactivity disorder, an episode of care for that. Which led us to do some for oppositional defiant disorder. We did for knee replacement. We did pregnancy and postpartum. We did C-section, upper respiratory infection. So we did a number of those and looked at that, and it just didn't address the cost for our high needs population. So it was touching the broader Medicaid population, but it didn't really zero in on those needs for that population. We also looked at institutional care, and it accounted for about 1/3 of the total developmental disability claims was for institutional care. More than 2,900 people were on the waiver wait list, accounting for $32 million in Medicaid costs for 2,640 people. So those individuals, while having spoken to so many of them since this project started, knowing that they were doing amazing job in doing case management for their children. They still had this high medical cost, but we weren't able to provide those other services or that case management services. Supported living accounted for about 96% of the spending on individuals receiving IDD services, and the mental health system was highly fragmented. And we had dually diagnosed clients that were dually diagnosed with DD and BH that were not receiving appropriate services because of the way we fund those services. We have programs for DD, and then we have programs for behavioral health. And then when providers tried to serve someone with having both needs, they had great difficulty, because if you document something in a chart for a DD client that's really behavioral health in nature, you need to do that with a different program, and vice versa. So there was some great difficulty treating clients that had needs in both areas. Beyond just the financial issues that we were having and looking at those financial pieces, we had a real need for new home and community-based services. We're using behavioral health services to fill a gap there. So the program that we were using, the Medicaid program we were using for behavioral health clients, did not allow us to really truly provide home and community-based services. So the providers out in the communities were using things like group therapy, and we looked at the data, and there was a high usage just compared to other states. Huge usage of group therapy. And in speaking with providers, we realized group therapy was not really being used for group therapy, but it was being used to provide more of a home and community-based service. So it was being used to support individuals. They would come in, and service providers would be able to lay eyes on them. They would be able to check in with them. They'd be able to monitor them. They'd be able to supervise them. And that's really the need that was there and what they were providing, but it was really getting billed out as group therapy. So we knew that there was a need for true home and community-based services that could be provided for that population, and that people could actually document to those services and bill to those services. We had a rising cost of care, and we didn't have improved service outcomes to correlate with that rising cost of care. So talking about it not just being about the cost of care, but I think if we had improved outcomes and we were treating more people, that there would be a different thing. But we saw that the cost was rising. We had no coordination of care for specialty populations with high needs. I know that within the DD waiver, case management was provided, but for the behavioral health population of about 80,000 people, we had no ability to pay for any case management. That was not a service for which providers could be reimbursed. We had a lack of primary care access for those with high needs, because some individuals that had difficulty obtaining a primary care physician because it was just difficult to make sure that they had that support to show up to the primary care physician, that they kept their appointments, that they followed the recommendations of that primary care physician. And this a lot was on the behavioral health side. I know with the DD providers, you have made sure that you've gotten the people that you serve those services. So a lot on the behavioral health, but also just people that are difficult to communicate with, and people more difficult to serve primary care physicians we're not accepting as we would want to see. We also had a lack of access to services. And really, we didn't have that ability to standardize service across the state. So you see a lot of services being provided in high population areas, and depending on what providers were there, you may see really wonderful services. They had an ability to do fundraising they could provide, but we didn't have any real standardization across the state. So you might get a service depending on where you lived instead of based on your need. We had a reluctance of specialty service providers to accept difficult clients. So we had people leaving psychiatric hospitals with no one that would want to accept them into outpatient service programs, and particularly those with justice involvement. We had much difficulty finding those. We had a fragmented service approach to clients who were dually diagnosed, which I touched on earlier. And we have a high utilization of one-on-one direct care staff. We knew that we didn't have that ability to fund real service innovation. So when you have a program that's fee for service, you write the service array into the package and the providers provide those services. And so an ability for Medicaid to reimburse for any service innovations or any individual types of service programs didn't exist. We knew that it was very difficult to customize services and that connection, that statewide connection just wasn't there because we had providers that we had a relationship with here at DHS within a certain area. I really like the story that Tanya just told, because I think that really speaks to our ability to now connect services and how that didn't exist before. There really wouldn't have been a place for someone to call. So why was the PASSE model chosen in all of this? If it just went back to the financial needs and we had some unsustainable growth that we were looking at, that we had been asked to look through, and the Arkansas Legislative Healthcare Task Force was appointed by Governor Hutchinson, and the Healthcare Task Force hired consultants. The consultants came in and talked to us at DHS. They talked to providers, they talked to beneficiaries, they talked to legislators to try to look and see what they needed to do, particularly for our unsustainable growth in the Medicaid program, particularly for these specialty populations. And in looking at that, there were many different proposals that were brought forward in that. And probably the easiest proposal we could have gone with was, if you just want to save money, is to cut rates or to cut services. We could have done that very, very quickly. But we really believed that all of those issues that we talked about on the previous slide that we went through would not be addressed by just cutting services or cutting rates. It would have actually made things worse. And we didn't want to do that. So we studied other state models. We studied how regional care coordination organizations worked in other states. We continued to work here at DHS with stakeholders and beneficiaries, and we really came up with this third way of addressing all of our issues as well as our financial issues, and came up with the organized care model, and that was developed in 2016. That went back to the task force with all of the other recommendations. There were several, and the task force voted that the organized care model for the BH and the DD population would be the model that we wanted to embrace as a state and we wanted to put forth. The task force selected it, and then it was passed in Act 775 in March of 2017, and we've been working diligently to get this model up and running since then. So now that I've set up what the model is, I'm going to let Lainey talk to you about a further explanation.
Okay, thanks. So first of all, I want to remind you that we put these resources out there for you. If I go over anything too fast today, we tried to put these resources out there for you, but we also have it on social media and our website, so you can get access to those. But let's go back to basics. What is a PASSE? It stands for Provider-Led Arkansas Shared Savings Entity, and it is a model of organized care, which Paula said was created by Act 775 of 2017. Providers have entered into partnerships with each other along with an experienced organization that helps them with the administrative functions to all group together and form together like an insurance company. So you all know how insurance companies function. So you should kind of understand how the PASSEs will function. The governing body of each PASSE had to include several types of providers, which included a developmental disability services specialty provider, a behavioral health services specialty provider, a hospital, a physician, and a pharmacist. And that is really why we need all different types of providers to join these networks. The purpose of the PASSE model, there are many. And as Paula just kind of told you, I'm just going to briefly talk about this, to improve the health of Arkansans, to link providers, to coordinate care, to allow more flexibility of services, to increase the number of service providers, and to reduce cost by coordinating and providing appropriate and preventative care. Who is served by the PASSES? There have been some misconceptions that every Medicaid recipient, which Paula just said, not every Medicaid recipient, there are only certain ones. Individuals receiving services through the DD waiver, individuals who are on the DD waiver wait list, and individuals who are in private DD intermediate care facilities. They will be managed by the PASSES, but also individuals who have behavioral health diagnosis and have received an independent assessment that determined they needed services in Tier 2 or 3. Who are the PASSES? I know that was your next question. These are the PASSES, and we gave you the contacts for the PASSES on one of those resources out front, but this slide shows you the main contacts for each PASS, but also the care coordination contact for each PASS. What do the PASSES do? Well, right now we're in phase 1, and right now they are providing care coordination. But starting on March 1st, each PASS will receive a global payment, and they will become responsible for members' total cost of care and accept full risk. What services are covered? Now I want to allow Paula and Melissa to quickly elaborate on these, but you can see on the screen the list of the services that will be provided, but I'll let y'all talk for just a second.
So the PASS must cover the state plan services, so your basic services. And Melissa, you may have to do this because I cannot read that little tiny. I didn't bring my reading glasses up here. But services like personal care, durable medical equipment, occupational therapy, physical therapy, speech therapy, hospital services, physical therapy. So all of those medical services that are in the state plan that are accessible to anybody with that has Medicaid, that is a Medicaid eligible beneficiary. And then the services that are provided by the waiver.
So I'll try to, can you hear me on this little mic? Okay. I talk loud, so it should work. So in addition to state plan services, and I get asked a lot. So, oh, thanks. That's a lot bigger. That would include early intervention day treatment services, adult developmental day treatments, or anything that's been written into the state plan will continue to be covered under the PASS model. As far as DD waiver services, which is also called the Community and Employment Support Waiver, the same service package will be available under the PASS. And I think what's really exciting is that we have a whole new set of services that will be available within the PASS model that the DD community can access. And those are services that are in the Arkansas Independence Program. It's another waiver-like package, but if you get the handout outside, those are the new services on the bottom right. They sound somewhat similar to the Community and Employment Support Waiver services. There's a reason for that. So these services were specifically made for clients that have behavioral health needs and clients that will be putting into a duly diagnosed bucket. And so they sound very similar to the DD services you guys are familiar with, but yet they have to be a little bit different in order for CMS to approve. But we do know that these services work because they work over for the DD side. So some of the new services that I think we're particularly excited to see start would be the peer support. We have clients on waiver that are already trying this, that they have a peer support person that might be higher functioning, that's able to help them with a job or come in and hang out with a client during the day. So we're excited to see that grow. I'm particularly looking forward to mobile crisis intervention for the DD community. We hope that this operates exactly like it sounds, which is we have a kind of an acute situation with a DD client, and rather than contacting the police, we contact the 24-hour PASSE emergency hotline, and we ask for a mobile crisis unit to come out and help de-escalate a client. So, of course, this would not be used for all situations. We're not talking about homicidal, suicidal ideations, but we are talking about clients that just something has made them mad, right? The direct care worker has done something that maybe they shouldn't have done, or maybe the client's just having a bad day, and they need help de-escalating. We're not trying to take the place of a psychiatric unit by any means, but we do think this will work on clients, and it has worked in other states.
I wanted to call out one that I'm particularly excited about is supported life skills for the behavioral health population. So I know for the DD waiver clients, they've had supported living for many years, those that are on the waiver. And back to what I was saying about group, you know, so people were using group because that was the code that they could build to help people with basically checking in on them and making sure that they had a meal and that they were taking their medications, and they would show up to a group and they would make sure, you know, is this an adult who's living alone and they may not be taking their meds, and you kind of see those signs. And if you're part of the behavioral health community, you know the signs when somebody's coming off their meds or has not taken their meds or they've had a life event. But this supported life skills would allow providers to do exactly what is needed there, and instead of you know, trying to provide a medical services or a medical intervention or a treatment intervention, is what the person really needs. And if that's what they need, they just need someone to check in on them. Yes, thank you. In addition, one of the things that we added with some changes for children and youth were we added behavioral assistance. And so it's exactly what it sounds like. That's done in home and community settings, and someone, most likely a paraprofessional, can go out and support someone who's having a behavioral problem, help that individual learn new behaviors, develop a behavior plan, and then maybe support teachers and or parents in developing a behavior plan. And as you're listening to that, you can see how that could be across both populations and a dually diagnosed population, which is something that we had not been able to do. We developed services for those that had behavioral health issues and those with intellectual and developmental disabilities, and we just couldn't mix the two. But in these cases, those services can serve many types of people, and one provider could provide those services to many different populations.
Yep. Yeah. So, okay, sorry. There's no slides back there, so it's throwing me off. I don't know what's going on with that. So we have one working, so that's good. What services are covered? So Paul and I just went through the new covered services, and be sure to pick up one of those infographics outside if you don't already have it. I think it's helpful, and it is online. But there's certain services that will remain the same, meaning that providers will bill Medicaid fee-for-service through the MMIS system, just like you guys have always done, which is non-emergency medical transportation, referred to as NET, dental benefits, which of course now are through a managed care model, and school-based services provided by school employees. So this would be occupational therapy, speech therapy, physical therapy, and then behavioral health related therapy that is for counseling that's performed at school by school employees and billed through the school. Will continue to operate like it does today.
So, which of your providers can join a PASSE? All types of providers can join a PASSE. Each PASSE is required to operate on a statewide basis, so we need all types of providers. Providers are allowed to choose how they want to participate. They're not limited to the number of PASSes in which they can participate. Can I say that enough times and enough different ways? We just want to encourage you to join the PASSES if you're a provider. A provider might want to join all of them to ensure that there's continued coverage for the people they serve right now. Providers can't be excluded as long as they accept the terms of the PASSE and are qualified and licensed for our state. The Arkansas Any Willing Provider protections apply to the PASSE. And I know as a beneficiary, you care about this because we love our providers, right? So we care about that. And we want to encourage our providers to join. What should a new member expect? A care coordinator is supposed to be contacting you once a month. They must contact you within 15 days of your assignment to a PASSE. You will get a welcome packet from the PASSE that tells you what the PASSE is going to help you with. And that is right now until March 1st. Those things are happening and have been happening. But starting in phase 2, you can continue to expect those things to happen. But also, the PASSE will be responsible for working with you, the member, and your family to create a person-centered service plan, which is your plan of care that is individualized to you. And each of you, each member, will receive an ID card from your PASSE, so it will say your PASSE on it, but it will also have our PASSE logo on it, so your provider can know that you are a part of the PASSE. Let's see. This is what, as a new member, you shouldn't have to experience. And basically, we don't want you to feel pressured to change PASSES. If you like your PASSE, feel free to stay with your PASSE. It is your decision. So we want you to feel comfortable with that. If you are being pressured to switch PASSES, you can call 1-833, and this is on the screen, 1-833-402-0672 to let us know that you're being pressured to switch PASSES, and we would like to listen to what you're going through and help you. So we've kind of gone over right now what's happening, what will happen until we start on March 1st, 2019. So currently we're in what we call phase 1. You'll hear us refer to that. All members have been receiving independent assessments. Care coordination is being provided by the PASSES. All other services have been fee-for-service and will continue to be until March 1st. So the way things have been will continue to stay the same until March 1st. And yeah, I think that pretty much sums it up. PASSES are responsible for providing care coordination right now. They're responsible for just making sure that the services you receive, they're contacting your providers and finding out what services you receive right now. They're organizing a formal network of providers, which is why we want every provider to join them. So we hope that providers are contacting them and that they are contacting providers, because this network is very important. Care coordination, I just mentioned, that's what's going on right now. So the PASSES are responsible for care coordination right now, and as they take on full risk. Care coordination assists adults and children to develop their person-centered service plan, and it facilitates access to needed services. So for example, I have a daughter with a developmental disability, and she has about 10 specialists. Some of those specialists we see every 2 to 3 years, and some of them we see a lot. Some of them we see every day. And so this care coordinator is going to help me manage that, which I think I do a great job of, but sometimes I might miss an appointment or forget, or I forgot to call the cardiologist and make sure our 2-year appointment was scheduled. So that care coordinator is going to make my life easier. That's kind of their job. So, and we can go over any specific questions you have when we get to the Q&A, but they are here to help. When we start March 2019 and the PASSES take on full risk, that is what we call phase 2. We do have a transition plan to help it be a smooth transition for people who are moving from fee-for-service to the new PASSE model. Multiple independent assessments will stop happening. The PASSES will receive their global payment, and they will make sure that services are provided for their members. Providers will then begin to bill the PASSes instead of Medicaid. Beneficiary cost sharing is not permitted, and that basically means you're not going to get a bill from your provider or your PASS as a beneficiary. DHS will continue to collect current premiums on behalf of TEFRA because it's how TEFRA people are made eligible for Medicaid. And payments to out-of-network providers will be limited to 20%, which is why it's extremely important for for you all as providers to join PASSes. What is the global payment? So starting on March 1st, each PASS will receive a global payment. And the global payment has been calculated by an actuary, which DHS hired. And it includes the entire cost of care of all non-excluded services provided to the members of the PASS, which includes, but is not limited to, specialty services like developmental disability services or behavioral health services, primary care office visits, hospitalizations, personal care services, and medicines. It includes any services that the PASS offers in addition to the services covered by Medicaid state plan and the waivers. It includes payment for care and case management and coordination. And it includes a cost to cover administrative expenses. How will the PASSes give back to the community? I think I'm going to let Paula and Melissa handle this one.
So the way this works, as Lenny was saying, that the PASSes get a global payment. So they get the total sum of what would have been paid out in fee for service, and they get that global payment in a per member per month amount. And so we're using some managed care rules here, but we wanted to build in something to say that each PASS, while the managed care rules that we're using, even though this is an organized care model, our Medicaid rules have some application there, is they have to use so much of their money that they get for services and only can use a portion for administration. That's a patient protection to make sure that the PASSes are not, or any managed care company doesn't keep a lot of money for administration and cut services so they can have a much bigger profit. So we're doing that protection. In addition to that, what we've built into this program is community investment. So they can use up to 5% that they would count on the administration side for community investments. And they can do workforce development, they can do education, training, IT. So what they're looking at is what's needed across the state. What are our gaps? What would be the things that would either connect people or strengthen communities or strengthen service providers, build up service providers, train service providers, so those services can be provided either in a more efficient way or in a higher quality way or an interconnected way. We want to make sure that we encourage that. It is called the benefit expenditure, and that's being calculated. And again, it's up to each PASS. The PASSes, since there are 4 PASSes, have also talked about working together and using their benefit expenditure, this 5% collectively, to do something for the state. That's not something that we've dictated, but the potential of them then putting all of that money together to better our providers, whether that's purchasing electronic health records or providing some level of interconnectivity or whatever project they decide, you can see how that would really be useful, particularly if they band together. But they may decide that they have something specific that they see for their provider community or in the communities that they're serving that they would do differently and not come together as a group. So just being given that opportunity and that mission to do that is something that we feel is important.
Oh,
I keep trying to pass this
I know
to
you do. So on the bottom of that same slide, so she talked about the giving back to the community. There's also another funding stream coming into this model, and it's through the premium tax that each PASSE will pay to the Arkansas Insurance Department to do business within this model. So we anticipate millions of dollars being generated through the premium tax every year. In the statute that was on some of the first slides Paula went over, which is Act 775 that enacted the organized care model for the PASSE, it also mandates that 50% of that premium tax collected that's paid by the PASSES will be used to reduce the DDS waiver wait list. So that's a very exciting thing in terms of from my office, because it's a brand new funding stream that was not available, which means we did not have to take from somewhere else in order to give services to people that have been waiting a very long time. We had some movement for the first time on that wait list in a long time last year when Governor Hutchinson redirected some tobacco funding, and we were able to add 500 additional slots. With the premium tax, after 6 months of generating that tax, so probably September the 1st, we anticipate and are making projections that we'll be able to add another 500 waiver slots to the model. You also notice that it said who's in this model. So the DDS waiver waitlist recipients are in the model, but not all of them. And I probably need to go in and clarify on that slide. So the only, the people that are on the wait list who are currently receiving Medicaid state plan services were independently assessed and moved into the model. There's a couple of hundred clients who are on the DDS waiver wait list who do not qualify for regular Medicaid because their income is too high. Of course, the income to be on waiver is much higher than regular Medicaid. So once we award a slot, we'll be able to give them full service. But for the 2,600 people that currently are on the DDS waiver wait list and also receive Medicaid state plan services, we also project with the premium tax that we'll be able to do an interim service package under this model for those clients to utilize while they wait. And the way that Paula and I worked with our financial team to calculate that interim service package is we said, you know, what families really could use is supported living, right? They could really use some help while they wait. So the way we have calculated that increased rate cell would be that adults would be able to utilize, oh my gosh, I always get this backwards. They'd be able to utilize 8 hours of supported living a day, 5 days a week. And for children on the wait list, it was 4 hours a day of supported living, 5 days a week. And by no means are you walked into that example. That's just the way we calculated the increased rate. What it would mean was you could use your increased rate to get any service that you saw that was on the screen previously. So it wouldn't have to be supported living. It could be all respite. It could be all peer support. It could be all crisis intervention. But we wanted to give enough money to that interim service package so that at a minimum you could get some supported living hours. Like I said, until we can fully fund a CES waiver slot. So that, I think that's what's most exciting to us. We anticipate being able to provide that, like I said, 6 months after implementation. So if y'all, we spoke in Russellville, and I was adamant that we didn't need a delay, and that was why. We do think the delay is helpful. We're working out things right now, or the, not delay, but additional time. So we're working out some things, and it's been helpful to us here at the state. But it just also was kind of bittersweet because it pushed the time frame back of when we would be able to offer some additional services to people. So, but we're excited, and we hope to be able to do those two things in September.
So the responsibility of the PASSES in phase 2 are a lot of the same ones they currently have, but they will be fully responsible for ensuring that every member receives the medically necessary services in their plan and for the development of that PCSP, and for maintaining that formal network of providers and even more so improving it. Also, there are some beneficiary protections. The DHS staff currently provide support for members who want to switch. We intend to expand that to a beneficiary support center, which we will be announcing, and you can check our website and our social media for all of that information. The new center will be providing support for individuals both prior to and when they are enrolled, and it will help them with unbiased selection, meaning which pass should you pick. They don't have any stake in the game, and they can help you pick the right pass for you without any pressure. The Beneficiary Support Center is for the beneficiaries that are managed by the PASSES only. And then also you met Dina, and she is here to listen to anything you all need to come talk to her about. We'll talk more about what she does, and she's already told us too. Auto assignment, the last day of the way we currently assign people to PASSES will be February 15th, and we'll start a new way. And Paula, can you just briefly tell us about that?
Sure. So currently, the way we're doing this is when you get your independent assessment, then if you get it before the 15th of the month, then you're part of that monthly auto assign, that attribution. And our attribution uses a method by which we go out and look at claims data, and we establish a score for your relationship with a service provider. And that relationship score is based on the amount of claims produced for you by that service provider, as well as the number of days you access services from that service provider. And then we go out and see in which pass that service provider is a network member, and then you get assigned to the pass in which your provider is a network member. Once we get to February 15th, we're going to do basically round robin proportional assignment instead of looking at that. At that point, you know, we've done independent assessments on almost all of our existing clients. So most people will be new to the system that get an independent assessment, and so that assignment will be proportional. One of the things that we want to do with that is have an ability as we go forward with this PASS model, as we get quality measures from the PASSES, which is something that is both required and important to us here at DHS, is to get those quality measures, is that we can also use that to assign people based on a quality measure and assign to high quality PASSES. And that will be for an active pass and one that is not suspended. The other thing is we won't have that big wait, that wait if, you know, you could have gotten an assessment on the 16th of one month and then you would not get assigned, you would not get attributed to the pass until the 15th of the following month. But when we go to our new model, the person will be attributed within 24 hours of receiving the results of the independent assessment, and the pass will get a payment within 7 days. And so people will very quickly be able to move into a pass and get the services they need. The pass will get notice for that individual. And this is really important. We have a lot of behavioral health beneficiaries who we've found, particularly adults, who really just seek services in acute hospital settings. They don't follow up with services in outpatient settings. We have some of the data, and it's really disconcerting. We have people that have gone to hospitals and gotten treatment for a behavioral health condition up to 11 15 times in a year with absolutely no follow-up care. So what we want to do is to make sure for those individuals, we get them independently assessed very quickly while they're in the hospital setting. We get them attributed to a PASSE, and so that PASSE care coordination kicks in, and they help transition that person back into a community setting and have them wrapped up in services and follow them. So that's one of the things that we're excited about with that move. I think the other thing is just to note that once that PASSE gets that assignment, again, that happens within 24 hours that they get notice, and then on 7 days they get that prorated payment. So they're completely responsible for that beneficiary as soon as they become a member, within 7 days of them becoming a member of the PASSE. Oh, and I didn't add that we're continuing the 90-day ability to change passes. So even though you're auto-assigned, that's something that continues, is your choice to change passes.
Yes, I'm sorry. It should be 2019. I'm still living in 2018, apparently. So yes, the last date of attribution into a PASSE will be February 15th of 2019. Thank you. So I'm going to handle proposed transition plan really quickly because I know you'll just have questions and we'll let Paul and Melissa answer those. So we do have a transition plan, and in that plan, it means that the PASSES must honor current person-centered service plans, which includes prior authorizations and current service rates for a minimum of 60 days. The PASSE cannot change that plan without consent from the member or guardian. The PASSES are required to make sure that all of the network providers are in good standing, and all PASSES must meet full network standards. So we'll talk more about that later. I'm sure you'll have some questions. So before we go to the questions, I want to talk to you just a couple resources that we have. First of all, open enrollment is a time period in which you will be able to switch passes if you would like. And due to adding additional time, we moved our open enrollment to May 1st to May 31st. So, okay. Okay. So open enrollment, May 1st to May 31st, and that is the time period in which you can switch a pass if you would like. And if you don't do anything, you will stay in your current pass. It's like other open enrollments. We got enough photos of that. I would like to remind you all, this recording will be posted, so you will be able to get this, and we will also post these slides. So if you need them later, we will provide them for you. So PASSE contacts, who would you call for help? Well, Dina's up here. She's already told you. As a beneficiary, you can call Dina. As a provider, you can call Tanya. But we kind of have an order that would be best. So if you have a question or an issue, the best thing is to first call your PASSE and talk to them about it and see if they can help you immediately. Next, if they can't handle the issue, we have some statewide staff members, which are on the next slide, but and also they are on the resource that we passed out front, so it's a map. And then next, if you have a concern or a question, please call Dina and talk to her. And then last, we also have AFMC who can help you with PASSE choice counseling. So these are the PASSE contacts. I've showed them to you once, but also here they are again. If you have any issues, they're also on that resource for you. So please call your PASSE if you have a problem first, but then these are the DHS contacts, which are also on that resource for you. And they are regional around the state. And Dina told us all about herself, and I know you all want to call her just because she's so nice and beautiful. That is her email address, but she has an actual office with other people in her office. Those are their contact information. And that is AFMC's phone number, which is also on that resource for you. So you shouldn't have to write any of that down. We have an email list here at DHS for DD and BH that you can sign up to get resources delivered to your inbox. So when we have a town hall like this, you can get an email that tells you about it. Or when we make some sort of important announcement, it can be emailed to you. Of course, we're on Facebook, and we release all of these graphics on Facebook and all of the resources that we develop for you. We have done a webinar like this before, so there's already a recording out there for you with this basic information. And most of what we do is available on our website. It's www.pass.arkansas.gov, and that is at the bottom of every resource that we've handed out to you. Okay, the moment we've all been waiting for. Questions? And if we don't get to a question for you today, we will have a record of them, and we will try to put something on our website that answers questions. So I know that there's probably been some online, and we'll have some in the room. So I'm going to go around and try and get you on the mic.
I'm here on behalf of a current Medicaid waiver beneficiary who's been on that for many years, who's Down syndrome, who is my stepson. And I just want to get down to a few basics because we haven't received some of the communications, his mother hasn't, that you're talking about, I think would have already been provided. He received his assessment, which was tier 3, but we have not received any contact from a care coordinator.
Okay.
And my first question is, how is that contact made? What is the form of the contact? Is it by phone? Is it by mail or otherwise? That's my first question, but I have several questions.
Dina, you want to come up here? This is for you, girl. This is your new job.
Well, and depending on when your child was assessed, depending on when your child was assessed, the care coordinator should be, depending on where he was assigned, should be contacting within the next 30 days roughly. But if something is going on, feel free to call my office. We can be more than happy to help you locate and identify who that PASSE provider is and get them to reach out to you.
Just so you know, the assessment letter was dated September 26. Okay. And then the next question is with regard to notification of being assigned to a PASSE, in which PASSE. How is that notification given? And as far as I know, we haven't received that notification.
Why don't we do this? Why don't we get with him after and get all this down so we can help him?
Well, I mean, aren't there other people here who would want to know the answer to that question too?
Well, it should be an exception, not the norm, because they're supposed to be contacting. It's not.
So the notification letter is generated. So I will just say, one of the issues we've had with those notification letters generating is the notification letter goes to the address that is attached to your Medicaid ID. And we've not seen this as much on with people that are receiving DD waiver services. We see this a lot on the behavioral health side, is that those addresses are not getting updated in the system. Particularly for those that have Medicaid through Social Security disability. So the only place that we can they hear me or not? It's not broadcasting. It's not broadcasting. So the issue becomes that the only place you can update your address, if you had to update your address, is with the Social Security Disability Department. Then that gets fed to Medicaid, and then we can use that address. And so we get a lot of return mail. So it may be a situation, but for everybody, to your point that everybody would need to hear that, is those letters are auto-generated after the independent assessment. once the attribution is done on that 15th of the month and you get attributed to PASSE, those letters are auto-generated. So you should have gotten a letter, we would say the week after the 15th at some point during that week if your address was correct.
End of October for him.
So if you got the results, yes, September 26th of the independent assessment, you should have
1st of
been,
November.
yeah, you should have been actually September 26th. You would have been assigned October 15th and should have gotten a letter that week. So we can go back and look specifically at your case to see why you didn't get a letter and if that address has changed or needs to be updated. But for everyone else, that's the timeline.
I'm not going to take just a couple more minutes, but I do think these are all applicable to virtually any beneficiary. We have been told by Easter Seals, with whom my wife has had regular communication for many years as a provider, that we have been assigned to a PASSE. Okay. So they are aware of that, but I just want you to know that we are not aware of that. And our address has been the same for 15 years and it's not going to change. So I just wanted you to know that as well. And then finally, I'd like to ask, when you talk about changing a PASSE and you have an opportunity to change a PASSE, why would you want to change a PASSE? I mean, why would, and is that regional or related in any way to address or something? I mean, I don't understand how the PASSEs are set up. Why are there a certain number of PASSEs and why would you want to change a PASSE?
Okay, so I can answer that and Paula can jump in. So the PASSEs are set up, they're required to do statewide service. So no, it wouldn't be you would change a PASSE due to region. What we see when people want to change a PASSE is they didn't feel like they got along well with their care coordinator. Or maybe they called and they felt like the day they called, the PASSE wasn't organized. It's personal decisions on they didn't care for that PASSE, or it is the fact that maybe the provider that they want to use is not in the PASSE they were assigned and they want to switch so they could continue to use that network provider. So it shouldn't have to do anything with region, but it's more of just a personal decision of they were attributed and they choose to switch.
Did I understand in February the 15th that everybody is going to be assigned a different or a round robin thing? If you've already been assigned prior, you just keep on it? Okay, thank you. I have another.
On the PASSE provider listing. So how do we get that? I'm just exactly in the same boat the gentleman earlier was in. I've been told we've been assigned. I called that particular PASSE and it's a cute little runaround card they have in front of them. And it said, oh, we don't show enrollment, but you will be able to keep the same services you have now until March, whatever. So they don't show that my beneficiary is there. But Easter Seals has been notified that my son has been attributed to that PASSE. Now my question is, how do I find out who's in that PASSE? Because my primary care is probably not, my psychiatric group is probably not, and I'm going to need to go to those people and get them in a PASSE. So I just want to know, how do you find that out?
So Paul and I are going to share this little mic, so forgive us. But I think I would encourage you to get that infographic for sure that has the care coordinator's contact for your particular PASSE. And if it's not on the website, call them and ask them to send you their network. That's probably the easiest way. They are updating their websites right now as they sign contracts. But I think if you want real-time information, I would call and ask that care coordinator supervisor. Do you agree?
Yes. And
Yes.
And since we also seem to be we've had two questions now regarding, and it wasn't an address issue. There's just been a few people that we had a Medicaid ID linking issue. It didn't affect a lot of people because we've done independent assessments and we have, well over 40,000 people in the past now, but there was a Medicaid ID linking issue for some individuals. So and that's one of the reasons we're out doing these town halls and introducing Dina, so you know the person to call, and then we can track down if there is a specific issue of why you haven't been contacted by a PASSE or why the PASSE is not showing you as a new member. So make sure that for both of these particular issues, please call Dina so we can get that tracked down.
Yes, I'd like to know how many how many clients each case coordinator would have.
So we have a requirement that they cannot have a caseload of more than 50.
That's quite a few. As far as the mailing out, that's just sent out regular mail, like the cheapest bulk rates that you can get. The chances of that getting destroyed in the post office is probably the highest. So if you haven't got a letter, there's a good chance it's in the trash can at the post office mail processing area.
If you haven't got a letter, Dina's your lady over there. Let her know. Okay, we'll go right here.
I have two questions. One is, you mentioned a couple of times that services packages would stay the same, but there's a major change related to transportation for individuals with developmental disabilities. And I would like for you to address the impact of that change and what it means for those of us who have DD individuals who are also in a PASSE. And my second question has to be related to appeals and hearings. When there is an appeal of the assessment for which we disagree and have not received any information from appeals and hearings to indicate receipt of that appeal.
So let me start with appeals and hearings. So for appeals and hearings, if you are a beneficiary or a family member, you appeal here within DHS to the Office of Appeals and Hearings. If you're a provider, you appeal over to the Department of Health. As you can imagine, because the appeal is actually against us, we stay very disconnected from the appeal process in terms of there's definitely a wall put up inside this office. So the best route, if you're wondering about the status of an appeal, is to contact them directly. We have staff that testifies, and you have to remember your appeal is actually against Medicaid. So it would be Paula and I. So we do not get information outside of those appeals. As for DD transportation, so we have a card on this as well. So as I mentioned at the beginning, the PASSE will cover all state plan services, early intervention day treatment, and adult developmental day treatment or state plan services. As most of you guys know, we had two programs previous to those two, and they sunsetted on July 31st of this year. They were child health management services, which historically used non-emergency transportation, and DDTCS, which is developmental day treatment clinic services, where for many, many years they've had their own DDS transportation billing code. I put out a memo on this right before Thanksgiving that I'm going to have Lainey put up, because I have families calling me every day asking this, and I actually was a little bit late getting down here because I was talking to a grandmother about this. There's a lot of fear going on. There was decisions made regarding this program. We worked on this for many years. There was a lot of feedback that the non-emergency transportation wasn't as safe as utilizing vans for just strictly DD programs. As you can imagine, for net transportation, that's allowable to any Medicaid recipient, still allowable to every recipient and family member in this room if your loved one's on Medicaid. But it's for clients to go to doctor's visits, to get dialysis, to go get a colonoscopy, and it had morphed into being used 5 days a week, 4 times a day for approximately 18,000 recipients. So we had to choose, were we going to put those 18,000 within the net model, or were we going to give everyone that does developmental day treatment their own transportation code? And there was a lot of discussion that went into that over the summer. So I think some misconceptions out there is every single EIDT or ADDT provider can bill for transportation. They have their own set of codes now, and they actually have a higher rate than they've had in many years. We just raised it. It'll go into effect January 1. We're not stopping those providers from individually contracting with net brokers. What we are doing is we took off the restrictions for families where you no longer had to call 48 hours in advance every single time you needed a ride. And you don't have to make an attestation in front of us and God that you don't have another way to get there, right? It's a sure thing. They can bill it every single day. So those are the 2 things we did, and we think it's better for families, and we think it's safer for our clients. And so we'll get that memo out so we can hopefully die down some of this fear that's happening with our family members. And I apologize that y'all have been scared about it. And if you have direct questions, you are free to call me.
We will definitely get that posted. Here's another question.
Okay, this is a little bit long because it's about a situation that one of our parents, I work at a school district, and one of our parents had regarding Optum. I understand that's who you guys have that's doing the independent assessments. We've had a few issues with them, but I'm just going to speak to this one particular one. A parent had called the teacher. She was very upset because she had gotten a call by Optum, and they had told her that her Medicaid benefits were being suspended because she had not gotten the independent assessment done in the time frame allowed. The teacher called me and asked me if I would look into it. I am the special services secretary. I called Optum and I spoke with someone there, and I was told that they had initially contacted the parent the first part of October. That was as specific as she could get, or as she would give me. I asked what date did she contact her, and I was given the first part of October. I was speaking to her on October 26th. She said that she had spoken with the mom. The mom insisted that she did not want the assessment done in-home. She would rather have it done at the school. Our school is fine with that. We work with the parents to get a time and date set up and have a place for them to do the assessment. Then I said, well, okay, what is the problem? Because it's only been a few weeks. Why is she being told that the time has expired? And she said, well, the assessment would have to have been done by the 27th, which is tomorrow, and there is no time to do that. I said, well, if you just contacted her the first part of October, it has not yet been a month. I said, what is the timeline for these things? And she said, and I specifically wrote down, everyone's timeline and due date is different. It just depends. We don't know. I said, that does not make any sense whatsoever. She said, well, that's how it works.
And if I could jump in here, and that's actually accurate. So I'm assuming this is a new behavioral health client, right? This should be a new behavioral health client that a service provider, an outpatient behavioral health agency, made a referral for an assessment for this person.
No, this is a child that is receiving therapy services at a public school district.
But it is behavioral health. It's a mental health service.
It's personal care.
Oh, okay. All right. Well, that's a completely different thing then if it's personal care. I'm glad we clarified that. Yeah. So that is through our Division of Aging. One thing that we can note is that the personal care assessments do not impact the PASSE at all. So we can talk through that is not something. And then once individuals go into the PASSE, they will not need to continue getting a personal care independent assessment. But beyond that, while we manage the Optum contractor, is that we need to know exactly, because Optum contractors, the call center, if a call center is Optum call center is telling someone that they're going to lose Medicaid, they have not been given any authority nor given instructions to say that. And that individual who is making that statement about losing Medicaid eligibility or losing Medicaid at all would have would need to be that would redirected, definitely, if not more serious. So we need to know exactly, because Optum can go back through the call logs and determine who it was that said that and if indeed they said that. Now, one of the things that Optum assessors may say, or the call center might say when they're trying to schedule an appointment, is that you will not be able to receive this service after a certain date if you do not have the independent assessment, because we have authorization for personal care, because we have authorizations for services attached to that independent assessment, which is a very different statement about not receiving a service than losing Medicaid, but they shouldn't be saying that. So we would want to clarify that. And then as far as the timeline, one of the things we had to do, particularly for new clients, is we send referrals to Optum every day. And they're coming from behavioral health, they're coming from aging, they're coming from developmental disabilities. And for those new clients, and this really hasn't been the case for the developmental disability population, but we send a referral over. That referral stays open for a certain amount of time. At some point, we have to close that referral, because if we just kept every referral open for months and months and months, we would not be able to keep it all straight. And so one of the things that we've done is we have a close of that because people aren't responding. But the service provider who's providing that personal care service can then call and reopen that referral. But I think one of the things that we need to do is, for that particular incident, since it's really related to personal care, and neither of us are over the personal care program, and we're want to talk about PASSE today, and that will not continue to exist for the PASSE, is we need to get you connected to Stephanie Blocker or Mark White. So let's make sure we get her contact information, and so we can have someone call her about personal care.
Okay. Can I ask a question real quick? Just so you know about the Optum. Whenever I did ask her if because she said she'd tried to contact the school regarding it. She said she'd tried contacting it one day and there was never any answer of any kind. Well, our school has several people to back up and make sure that the office phones are covered. So that made no sense. And then she said the next day she called and got the runaround by someone, and she gave me the name. Well, it turns out she was calling the home and got a hold of the father. So she didn't even know who she was calling. She thought she was calling the school. She was calling the home. I really think the people there do need some more practice. We also had, just on a different note, a family advocate contacted me when all this was first going on, and she said that a family in our district had contacted her and said their care coordinator that they were assigned, they were talking to her, their child had autism, and their care coordinator did not know what autism was. They thought it was ID. And anyone that knows anything about any of this knows that autism and ID are absolutely completely different diagnoses, and there is in no way do you treat them the same. Do you set up a care plan or behavior plan or anything the same? And she was very concerned that there are people sending out as care coordinators that are not versed in what the actual diagnosis is for the people that they are supposed to be providing care for.
So Paul and I really appreciate that feedback. Let me say a few things about independent assessment. So we've assessed 70,000 people since September of 2017. Is that right?
That's right.
70,000. So we don't want anyone to have a bad experience at all. We don't. But when you do that kind of volume, we do need you guys to call us so that we can try to reach out to Optum and fix problems, right? That's a lot of assessments, and we expect to have some issues. We just need to be able to fix them. As far as the care coordinators, it's a similar situation. So we did not anticipate, we thought we were going to do a slow roll-in of independent assessments, and then we were going to attribute 1,000 clients to each PASSE each month, and it was going to be this amazing slow growth. Well, it just didn't work out like that for a lot of different reasons. We assessed 10,000 behavioral health clients in a period of just a few short weeks and attributed them to the PASSEs. The PASSEs were getting thousands upon thousands of clients every single month, and they were trying to bring on care coordinators. Same type of situation. Some of those people will work out, some of them will not, right? We continue to work on training modules that we think will assist care coordinators. That is one reason why we did the two-phased approach to this model, was knowing that we were going to have to get a lot of people up to speed on what we do, especially over at DD, right? That seems to be the huge learning curve for a lot of people. And so we know that we're not right where we need to be. And we are continuing to work with care coordinators to get them where they need to be. But don't assume care coordinators should not be making direct treatment recommendations to your diagnosis. All right? We're not replacing doctors with care coordinators. We're not replacing the treatment providers with care coordinators. Supported living providers will still turn in and be part and do treatment plans for clients. And the care coordinator, her job or his job is to coordinate those treatment plans and incorporate them into the one person-centered service plan. It's not to come up with innovative treatment for children with autism, right? And if that's what's being kind of the feel, that's completely wrong.
And just to add to that is this one of the reasons why, and we're really glad we were able to do this, is establish the Office of Beneficiary Support and the Ombudsman. And I will say that we've gotten calls that we get occasionally, because people usually don't call us when things are going well, just remind us things are going well. We get the calls where somebody has not performed in the field as they should. I've found all of our PASSEs to be very responsive with their care coordinator supervisors. And they need to know, having been I'm an old clinician, I'm a mental health clinician, and spent some time managing a fairly large home and community-based service staff. And these were all master's level clinicians. And they did things, and some of them were great, and sometimes their judgment just slipped on any given day, and I was always surprised. And you don't know what's going on out there until someone calls you. So very important, again, when you have something like that, have a concern, that you immediately call Dina in our ombudsman office, and that she's able to get in touch with that care coordinator supervisor, because as much training as we do at our level, that is the responsibility of the supervisor of that person, and they want to hear these kinds of things. So thank you for bringing that up, and that's something that we definitely want to address.
Okay. we promised we would get to providers. So I'm going to take a couple of minutes to go through the slides, and we're going to give you all opportunity also to be asking questions. So I told you what we would cover. We've talked about who is served by the PASSES. We've talked about what services are covered. If you are a provider of one of those services on the screen, you are affected by this PASSE model. We talked about this earlier. What should providers expect? The PASSE system is a shift in the way the client's care is managed and how providers will bill for those services. In the coming weeks, providers will need to contact each PASSE to find out how to join each PASSE's network and how the providers will bill PASSES for services starting March 1st. We've already talked, I think, in depth about why providers should join a PASSE, but for the most part, it's because you can continue serving the clients you already are serving. During phase 1, providers will see clients being assessed, care coordinators contacting clients to start plans of care, and providers, we hope, will be signing contracts with PASSES. Then in phase 2, the PASSES will be responsible for maintaining statewide networks. The PASSES will receive global payments. And then the providers of clients whose care is managed by the PASSES will bill the PASSES instead of Medicaid. How does care coordination affect providers? Care coordinators may contact you because as the provider of the service you provide, you are that subject matter expert for that client, right? So care coordinators may contact you for your client's plans of care to assist clients to make sure they continue getting services, to identify needs they have, and to coordinate multiple plans. How will the formation of person-centered service plans affect providers? You are on the PCSP team for your clients. We need your active participation to make sure that clients are served well. How can a provider join a PASSE? These are specific provider contacts if you want to join a PASSE, and there was a handout out front that you can grab if you need this and don't want to write all that down. How will billing be different starting March 1st? Well, the main thing is the providers will begin billing the PASSES, not Medicaid. Can't say that enough. I'll get to you in just one second. On March 1st for only the clients that are managed by the PASSE. What are the reimbursement rates? And I think I'm just going to let Paula and Melissa really handle this in depth here in a second. But these were calculated carefully. We'll just say that. And they were calculated to include the services that people need that in their plans of care. How and when will providers be able to check eligibility? Providers will be able to check the Arkansas Medicaid eligibility system after February 15th for PASSE assignments. We've talked a little bit about the transition plan and that PASSES have a plan to shift from fee-for-service to the new system. PASSES are required to ensure that their network providers are in good standing, which would include anyone who's in their network. And I think we'll handle that through some questions too. We have talked about how we would like for your clients to contact their PASSE first. So if you hear from a client who needs help, please direct them first to their PASSE. Then they can call Dina, the PASSE ombudsman, if the PASSE did not help them the way that they would like. And then AFMC also is available. Again, PASSE provider contacts, those are those specific ones at the PASSES who handle provider needs. And then also don't forget about Tanya. She's ready to help you and answer your questions. I know she's already answered a lot of your questions, have called her. We have a website, pass.arkansas.gov. Don't forget about it. And that is where we put all of our resources. We try to do recordings like this on there. If we do webinars, we put them on there. We'll put the answers to the questions we don't get to today on there. So please don't forget about that. And now we will continue with your questions. Yes, let's do some online and I'll walk back to somebody who has a question.
I've got one from David Jones that says, will tier 2 and tier 3 clients need to be reassessed January 1st? And so for the behavioral health clients, they must have an annual reassessment. And that's not 365 days from their first assessment. It just says that it needs to be annual. So for those individuals for behavioral health, had behavioral health independent assessment in 2017, those will have to be reassessed before December 31st of 2018 of this year. So that is a requirement. We're getting the list together and sending those out to providers to make sure, because Optum has been trying to contact those individuals, and we still have a handful left that need to be reassessed before December 31st. For the remainder of the individuals, what we did was divide that into chunks. As Melissa said a little bit earlier, we had an enormous amount of individuals that got assessed in about a 3-month period. So we're trying to equalize that out across 12 months, both for the beneficiaries, for the providers, and also for Optum staffing. And so what we've done is, for anybody that received an independent assessment between January 1st, 2018 and May 31st, 2018, we're moving the end dates of those assessments to May 31st, 2019. So all of those, and that's about 18,000 people, 16 or 18,000 people, and they will need to have those independent assessments. We're going to start calling those individuals here in the next couple of weeks and scheduling those reassessments. Then we broke it down a little bit further, with the last group being reassessed by December 31st of 2019. And we have an AFMC webinar this afternoon with the behavioral health providers at 2 o'clock, and we'll have that information. I want to do one more really easy one, Melissa, before I hand it to you. Winter Pass ID is going to be mailed to members. So the passes would start mailing those on February the 15th.
For reassessments for the DD population, we only we wrote that it would only be conducted every 3 years. We know that's a different population from behavioral health, where they see rise and falls in terms of your behavioral health. For DD, of course, where it's a much more stabilized group. Of course, you can always ask for a reassessment if the condition has changed, but every 3 years for us. And you guys, I think I've mentioned it before, Paul and I are actively working to develop the dual diagnosed independent assessment, so that clients who have behavioral health needs and DD needs can be assessed one time and one time only, and receive one tier amount. We think this will actually, for the first time, outwardly show that yes, there is such a thing as dual diagnosed, and give it a name and be able to provide services in accordance with that. So we hope to have, we were hoping to have that done in July, probably more like September at this point.
Hi, I have a question maybe for Tanya. Who do providers need to contact if we have a list of people who we aren't sure if they've completed their DD assessment, their behavioral health assessment, their personal care assessment? We need to find out what tier they're at and what PASSE they've been assigned. Who is the contact person for each of those assessments and PASSE connections?
So we have and there's a question, you have a question, you can probably pull it out of there. It's on that specific topic. Stephen McKnight is a employee with the Division of Medical Services who oversees large contracts, and he oversees the Optum contract. But in my office, Shelby Maldonado can assist you. She's been getting those calls and emails all day, every day. So feel free to reach out to Shelby.
And for the behavioral health clients, we have about 40,000 clients. And so we have not been able to have a place for you to call to see which pass and in which tier. We're working to make sure that tiers get displayed in the eligibility system. So we're working with our vendor so you could see that through MMIS. We have not gotten that done at this point in time, but we are writing that up to request that. For behavioral health clients, though, we are working with our privacy officer to make sure that we can look to see which provider a client is currently receiving services. We really just don't have a way to do that. We can look back at claims data. That's not very accurate. So for the behavioral health side, all we can do is look to see which provider has a current confirmation number for services. And then we'll be matching those confirmation numbers to the beneficiary and to the PASSE and sending those numbers out for sending us a list, a roster out to all the behavioral health providers.
As far as the change from January 1st to March 1st, we've heard a lot about that, but the providers, what does that mean for our care coordinators? Because now we're basically 100% attributed. Who's going to do the plan of care? Is it still fall on the provider care coordinators who are doing 2 and 3 jobs at this point and not getting reimbursed anything? We really need some direction on that, and how are passes and how is the state going to help us coordinate all of that?
Yeah, so I know that's a problem for DD providers. I sent out an email. I guess it went out yesterday, day before yesterday, and I put in there a sentence. I mean, I completely understand we're in the DD supported living providers are in a spot, right? Because you've transitioned all your case managers out, anticipating a March 1st deadline or start date. So we've been meeting, Paul and I have been meeting with the past CEOs, and each one brings a DD representative to meet. So we've had 3 or 4 meetings where we're coming up with the plan, which is what you saw in the email. Some of them are here today, but I wrote back to that small group yesterday. You know, forgive me, we do want to help. Explain to me how the waiver specialist can help in real terms, because we're pulling records today to see how many plans are going to expire in December, January, and February, right? Because according to if y'all saw my email, that's what we're focused on, because once we get to March 1, we think we're good in terms of how the agreement's written, and the passes will be able to simply extend. So we're going to focus on, like I said, those plans expiring December, January, and February. And I'm getting staff to pull right now, how many plans are we talking about? And then what can we do? And this DD work group is, I'm sure they've already emailed me at 7 o'clock this morning, letting me know what we can do to help. Is it helping with physician signatures and scheduling appointments? Is it helping with what? So that's what we've asked for to give. We want to step in. We know you're short-staffed. Do remember that the past care coordinator should definitely be in the room and helping y'all. And the past CEOs in the last meeting said the care coordinators could also help with getting doctor scripts and with helping do plan amendments. I think for me personally, that's a really good exercise to train them on what they're about to take over. So if you have problems with a pass not wanting to help, let me know, because they should definitely be helping. And I'm going to look, and I'll know exactly how many and which providers have plans expiring in those 3 months. And we'll be monitoring that.
I have a point to that and then 2 questions. So the point to that is that that's one piece of kind of the overwhelmedness with no staff that we've got going on right now, because we've got the minimum wage amendment adjustments that are going on. And so what we're seeing is that it's so convoluted in the conversations that's coming down. So we have folks that are trying to figure out, we do have a plan that's expiring in February. So we're trying to figure this out. And then we also have that same plan over here that we're trying to bulk mass figure out updates and notifications and things like that. So problematic on both fronts, just the point.
Yeah.
But, Paula, I think you just said this. You said it really quick and I missed it, but did you say that the PASSE member identification numbers or cards are going to be sent out February 15th? Is that what you just said?
That's right. And I'm glad you said that because I just saw another question and also didn't, I don't think I mentioned, I may have, but that you would also be able to go into the system just like you go in to make sure that somebody's Medicaid is active, and you check that before you provide a service or you check that on a regular basis. On February 15th, you'll be able to look in there and see which PASSE they're in as well.
So will we be able to pull their number? I mean, we will need that to bill. And so if we're looking at March 1st, we've already noted that the mail system isn't the greatest and that there are some issues in people getting the information that they need. And so if we're waiting on a beneficiary to get a card that's mailed out to them on the 15th, and then us track that beneficiary down and try to get that number so we can get in our billing system and be ready to bill by March 1st, I have some pretty big concerns about that.
Yes, and so, and you wouldn't have to wait on the card, so you would be able to put in the beneficiaries on the 15th of February. You would be able to put in the beneficiaries information like you do today, and that would pop up. And then we are working to make sure we get rosters out to you prior to that. And again, just working with the privacy officer now to, particularly for behavioral health. I think Dee Dee's a bit different. With behavioral health, we have clients that change providers often, and so we want to make sure that we're not sending protected health information out to the wrong person. But we are working on getting those rosters out for the DD beneficiaries. We should have that out.
Rosters are ready. We're just waiting on the rosters are ready on our side. We're just waiting on Mr. Brader in legal to give me the thumbs up. The rosters. Well, right now we want to get it out just because you haven't gotten one yet, right? So you have a baseline. Then once March comes around, and we can probably do another rollout before March, and then March we'll have to figure out from the PASSES how they're going to keep people informed.
Well, I mean, it's going into that system. So let's think about that. So if we get it out in December, then we would want to get it out after the December 15th attribution. And then we would need to get it out to you once more and do any updates for January attribution. And then you would have it for the February attribution. That's right. And that is, it was the date of December 15th was given because we were converting all of our data for a January 1st start date. So we are converting from the fee-for-service MMIS system to a managed care module. And we can't convert that data until we're ready to go to PASSE. And so it cannot run, believe me, we have, yes. So we've done many workarounds to do this phase 1 of PASSE. And so we were not able to do that until that last moment before we go to full risk PASSE to phase 2. And so with the delay of the PASSE, we also did a delay with moving that system.
I have one final question. So up until Thursday of last week, we were continuing to get review sheets, plan approvals, and prior authorizations that were end dated 12/31, despite us communicating many times that it's not 12/31 anymore. Why are you sending us these PAs? On Friday of last week, we started getting review sheets and prior authorizations end dated 8/31 of 19. And with the language that says that the PASSES will assume the payment responsibilities September. And then yesterday we got the notifications in March. And so just some clarification on where we're at and what's going on with the billing authorizations that we're seeing.
Right. So I know from y'all's perspective, It just seems like chaos. Debbie's in the back of the room. Maybe she'll back me up on this. We keep meeting with our DD representatives and our PASSEs. Each time we'd meet, we would try to come up with a plan, try to see how much work it was going to be to implement that plan on the providers and the clients, and then come up with new ideas at the next one. It was a moving target for about 2.5 weeks. Unfortunately, you guys know I have 2,200 staff. It's hard to push messaging down, even when you try. The memo that went out to you guys on Tuesday is hopefully the final word, which says, please focus on plans for December, January, and February. We're going to PA them till March the 1st. I could have PA'd them till August the 1st or November the 1st. It wouldn't have mattered. On March the 1st, if you try to bill MMIS for that date of service, it will deny you. So after February 28th, you will no longer be able to bill MMIS for clients in the PASSE. So I did March 1st just so it was a little bit cleaner. And I think BH is going to use the same date. That's only on the PA. And so the plan should still run a year. We're not asking you to shorten those plans. In the agreement that DHS has with the PASSE, there's a transition plan. And there was a slide on this, but in that transition plan, it mandates that they can't change service for 60 days, and they can't change service without having a person-centered service plan meeting with the client and the guardian and all be in agreement. So the transition plan lasts up to 6 months. They have the ability to go in through that transition plan that's been approved by CMS and extend plans. So that's why I'm real concerned about all the ones up until March 1. And then I think at that point we'll be okay and no one will fall through the cracks. So that's kind of, and the BH on the same vein is doing a similar plan on how they're going to extend the PAs.
2 o'clock today.
Oh, at 2 o'clock today.
2 o'clock webinar.
Hey, Melissa, what Sarah's saying is providers are still getting PAs with the end date of like August of 2019. Those just started coming out. We understand that those rates will be extended and those plans will be accepted beyond the 6-month date or beyond March 1 day, right? 6 months, out 6 months or.
So the PA date has no, I know it's frustrating to get different dates, but what I'm saying is the PA has no bearing, because if you do date of service March 1st on and try to bill MMIS on that PA, it'll deny you. Okay. So it's an arbitrary number. All right. It's unfortunate that we have different numbers, and Stephanie Smith actually emailed me yesterday the same concern, and she saw me email waiver administration and say, please get this corrected on these face sheets, right? So that we're all using the same number, but it won't detrimentally affect us in any way. If it's March, August, October, November, it will not matter. I think the key to it is make sure when we're going in and doing extensions on these plans that you go ahead and make them for a full year. And my hope is that the PASSEs get a little busy and they just leave our plans alone. So I'm saying don't make them shorter. If they expire, the PASSEs can go in and extend them, but go ahead and do a full plan year.
I have a question.
Hey, Lisa.
I'm sorry I didn't recognize you actually earlier. My question is regarding the assessments. I was told that a tier logic caregiver domain is being worked on for the assessments. They came back not correct without going through an appeals process,
Right.
that they're actually working on implementing this caregiver domain tier logic. And for those whose assessment came back not at the correct tier, it'll automatically be put back through this assessment and will be tiered correctly.
So,
but I've been unable to get any, I was told this through the supervisor at Optum, but
Right.
I've been unable to get confirmation.
So Ms. Fassard's asking about tier logic. So let me just say this. We're not changing any of the logic on the independent assessment. We do think there's a training issue around how they ask the questions on the caregiver domain section. And I've gone in and rewritten the section with Optum. We've come up with a solution on how to better train their assessors to ask the questions. We did a quality review on the 2 you sent me and the tier went up. So I don't know, your staff were supposed to call you. So yeah, okay.
I'm really glad to hear what you're saying about your assessors, because I know the assessor that we had, I personally asked him his experience, his training, and he was just hired for that job and given, I guess, the training provided to ask the questions. He didn't allow you to elaborate on any of the answers, which is critical.
Right.
Their lives aren't simple, and
Right.
There's more explanation than a clear yes, no, answer.
Mhm.
So I'm really glad to hear that that will change for the future. And I'll check on the others of what you're saying, because I've been unable to get an answer. So
Call Shelby Maldonado. I've had her work on your 2 cases.
We'll get you that. Okay. It is 1:59. We have 1 hot question left that hopefully we can address quickly. We have a ton of good ones. And Ruth said, I saw her. Did you see her pop up? She said, are we seeing your questions and how are we going to address them?
Well,
We
I
are
have
going-
Ruth's questions right here.
Well, she has more.
Okay.
But we are going to address questions that we didn't get to online through a document that we'll release. And if there are any in the room that we don't get to, please, there's a card up here you can write on. I want to give you this hot question. Is there a way to address that?
Please explain in plain language the transportation issue relative to to day programs like Easter Seals. Let me get this memo out, guys. I know this is a hot topic and I'm getting a lot of calls on it. But I'll just say it's a state plan service. It'll be in the PASSE. It'll be a covered service.
Okay.
The PAs, I understand that they end in August, that's the midpoint of the deal. What about the ones that end December 31st?
All PAs that are currently ending December 31st for BH and DD, we will go in and extend till March the 1st. So I'll do it through a PA and you'll do it through a confirmation number.
Yes, and I'm sorry, I'm going to have to leave to go to this webinar for behavioral health. So thank you so much. But if you have questions about the behavioral health authorizations, then we need to get on that 2 o'clock webinar. We're going to hit it at 2:15 and talk through all behavioral health questions, including some questions. I think there were some questions here on Medi-Medis on people with dual eligibility. So
before you all run away, do not forget about our website, pass.arkansas.gov. We will have more town halls in which you can ask questions. So please don't forget, that's where we will announce.